Hello everybody. Here's a new series that we have started. It's called Dental Matters. In our close-knit community, we get a lot of questions which we try and answer. Since the questions are increasing in number, we decided we'll take it a series of topics on. So every few weeks, you will find us answering on few topics. So you could put up your questions when we ask, and then we could come with a series of dental matters. In this Dental Matters episode, the question was about extra canals. Now there were some other questions asked. What if extra canals are present? What if it is missed? And what are the complications? I think if you have missed an extra canal, you only can pray. But you have to follow up. If there's a missed canal, then the only way I do is, if I've seen a canal that's been missed by any clinician, I wouldn't want to re-enter immediately. We would want to follow up every 3 months, 6 months, 9 months, and maybe 12 months. So in the 1 year or the 1.5 years, within 18 months, you'll get to see the good or the bad, which means the opacity or the lucency increases or decreases based on if there's a lesion. That's the principle of how healing or failure happens. So if you see something is going wrong, I think you need to arrest it. You need to advance towards trying to find the extra canal. Sometimes there may be a clinical interpretation, which might mean in a form of a flare-up. But there are times I've seen for years, if the local immunity is good, the canal remains silent. It just doesn't trouble. So you need to work on certain things of how to treat, or do you need to treat or not. There's another question: what if a canal is missed and what protocol do you follow? I assume this either you have missed the canal or some other clinician has missed and the case has come to you. If you missed the canal and if you need to find it, look at which tooth it is. Again, you follow the laws of symmetry. There are access cavity guidelines. The canal is always in the floor, not in the wall. So floor is always darker in color than the wall. At times, because of extra deposition of dentine, the canal will climb the wall. So maybe you have to move the wall away to bring the canal down. That's it. But again, like I said, this question is a very generalized question, so it depends on which tooth you have missed the canal. Commonest extra canals are what? In the mesiobuccal root of a maxillary first molar, very commonly seen. A mid-mesial of the lower teeth, the first molar is most common. Sometimes radix, intermolaris or paramolaris. The extra second linguals on the mandibular premolars or the mandibular incisors. So these are few of the teeth which are generally having extra canals. Variations still can exist, like you see the C-shaped canals or maybe the dens cases, the dens invaginatus and others. So there are plenty of other variations too, but the commonest ones is what I mentioned. If I have to see another question now, in case of CBCT is not available, how can we confirm the absence or presence of MB2? The question goes this way. Now, MB2 is relatively present, a good incidence. I think one of the recent articles in JOE in 2018 said that it is as less as 48% or as high as 95-96%. So even 48% is close to 50%, is every second case. And if it's 96% is almost every case, right? So that's the kind of incidence in different countries, and this is a systematic review. It's a meta-analysis studied in different countries and then put together, So it's one of the good papers published recently. So anyway, so when you know there's an extra canal, you need to find it. But I'm not sure if CBCT will always find it. It also always depends on the voxel size. If the beam or the ray that is bisecting the canal doesn't take it enough, or if there is enough deposition of dentine and it's not in the line, it may not capture. That's the same story which goes with micro cracks or fractures, small little cracks. You can't find them. Added to which the complications are what? Generally these teeth will have a filling or a crown or a post or a core built up like an opaque material. These materials end up having some scattering, due to which the specificity of the MB2 being found in the CBCT becomes relatively low. It becomes relatively low. So you need to understand this, that CBCT may not be the only answer to find an MB2. First and foremost would be a good clinical judgment. CBCT can be an adjunct. So that's my answer to that. The next question would be about tips to locate MB2 canal. I would like to keep it short here. In fact, we've recorded about close to 4 hours of video presentation on MB2. Try and follow us up there. You will find every reason of how to find an MB2, what's the incidence and prevalence, what are the shortcomings, how to treat it, once you found it, then how to treat it, how to complete the case, and even after finding it has failed, how to surgically treat it, and what are the various other reasons around MB2. So much about MB2. Quickly, if I have to tell you, I'll just tell you 3 points. MB2 is in the MB root, so it has to be more on the mesial and buccal side. Earlier books have said a line drawn from mesiobuccal to palatal, it's in the line. But today we find it's more on the mesial side of the line. So you do not a triangle outline, you do a rounded triangle outline in the mesial wall. And the second point is, if you draw an imaginary line cutting 2 halves, buccal and palatal, it's always on the buccal side. And the third clinical tip would be, at the horizontal plane, if you see the canals, all the canals may be in one plane but not MB2. MB2 will be much deeper, much lower, maybe a millimeter, maybe 2 towards the root surface, towards the cemental enamel junction surface and downwards. So these are the few tips I'd like to give on locating MB2, but there's more and more clinical tips on the videos that we've recorded. Follow us up there. One more question is how to locate MB2 canals in upper molars. It's almost the same question that I answered, but if you ask me, the question is good. It's upper molars. It's just not the first molar. First molar has a very high incidence, but also the second molar and the third molar also have MB2. The incidence is much lesser. It's less than 20%, they say, but it's still there, right? That's what it is. Here's another question of what are the guidelines to treat extra canals. First, of course, an ideal access cavity preparation. Once you've prepared it well, if you have a virgin tooth, which means there has not been any calcification happening in the tooth, like a young tooth, then possibly you can see the dentinal map. You can trace it. This map in the floor will take you from one canal to another canal. Also, you see the floor color. I told you the floor is more darker than the wall. There are a few other tests that you can do, you know. If it's a vital tooth, there's something called as a red line test. Try and work on one canal, the main canal, and then you'll still feel the blood or the tissue fluids trickling down to another canal. That'll get you the guideline. And if it's a non-vital tooth, sometimes you may have to dig it with ultrasonics or burrs, and some debris will start catching up in the same groove and carry it to another canal. That's called the white line test. You can have a champagne test, which means a bubbling test. You can put a hypochlorite, a sodium hypochlorite 5% into the canal spaces, and because of the oxygen liberation of the tissues, because they're organic, they will start bubbling. These organic tissues will bubble, and that bubbling will give you an indication of entry point. You can do some tests like a probing method, a walking method, a transillumination. You can use some indicators, color indicators, some dyes sometimes. There are so many mix and match techniques that you can use, which I have covered in detail on a topic called as MB2. So this possibly could answer all your questions in those videos.